Can we talk a little bit about women now? I know we talked about it earlier, but can we go a little bit further onto the topic of women and just really focus on that? I think a lot of women find it's harder to get diagnosed since doctors are looking for young men. But can we talk a little bit of differences in terms of, onset and estrogen? We talked a little earlier, but can we really focus on women?
As you mentioned, this is a group where sometimes the diagnosis gets delayed because the classical patient with LON will be a young male, and therefore sometimes people don't think about it to start off with. There was only one study, perhaps Valeria and Alfred will confirm that, from Anita Harding, suggesting that there was a difference in terms of age of onset with female carriers with the 11, 7, 7, 8 mutation, but that has not really been shown elsewhere. So I think that's the only case series I'm aware that has potentially shown that it's different age of onset.
Yeah, and that particular study by Anita Harding, the age of onset of women was shifted slightly later than males, but we need to run proper studies to demonstrate that, which could mean that you have certain amount of female getting the disease in the traditional age, like in a young adult age, and eventually a second hit in the postmenopausal period, or in specific clinical situations where you are not having the right amount of estrogens, like primary amenorrhea, or in the postpartum period. I have a few anecdotal examples of females actually getting affected after delivering the second or the third baby. So it's all anecdotal, and I would be very careful of making any statement about this. We need to run properly designed studies, epidemiological studies, so we need to investigate very large cohorts of people in order to produce a solid statistical relevant results.
Maybe just one simple take home that might be useful. Women are less likely to get the disease, depending upon mutation, different amounts, but you're lucky in that regard. But if you get the disease, it's the same disease. They don't get a mild version of it. In my experience, had excellent rapport, and again, most of these doctors don't have any experience with labors and are very happy and willing to work with us. The only pushback I've gotten with a little bit of regularity is from OBGYN. And it usually is not the patient who has lost vision that is the issue. It's usually his mother, to which I say, I really would like you to not go through menopause, because that is a second risk period. And I provide a note or an explanation which is brought back to the OBGYN, who says, it's not my policy to give hormone replacement therapy. And then usually I come back and says, yes, but 15 years ago it was your policy to give everybody hormone replacement therapy. I know that the pendulum swings and the fashion has gone from every woman should be given estrogens to, oh, well, that can reduce strokes and heart attacks and none can. And my argument usually goes, let's customize it. Let's understand that even back then, it would have been a very bad idea to give estrogen to somebody who has the BRCA mutation for breast cancer, because that's just begging for trouble. Here we've got sort of the flip side. We have another mutation that makes estrogen a particularly useful adjunct. So rather than just look at that large population, let's focus on this population and recognize that in the risk-benefit analysis, there might be some value to it. And usually by the time we get to that part of the conversation, the OBGYN recognizes the situation and says, well, which one should she go on? And I say, well, that's where you're the expert.